So welcome to our August Heart to Heart session. Tonight's guest speaker is Dr. Melinda Hass. Dr. Hass is one of our general surgeons here in the Quad Cities. She's also the medical director of our Weight Loss Management Center in Moline at the Trinity campus on 7th Street. In addition to that, Dr. Hass is the medical director for the Breast Center for Trinity on 7th Street. She completed her medical training at the Harvard College of Medicine at the University of Iowa, and then her general surgery residency at Mayo. Dr. Hass is also board certified and a fellow of the American College of Surgeons. So, welcome, Dr. Hass.
Hi, everybody. Well, Dana, thank you for that introduction. And the one thing I also want to add is that this is my 24th year here practicing at UnityPoint Trinity. And so I've been a proud member of the medical staff here, and I love Trinity, and this is a great place, and love to be able to provide care here in the Quad Cities. I'm from the Quad Cities initially, and from Davenport, and my family's all still here. So I do see some familiar faces in the crowd, and it's nice to be able to be here to talk to you. And so before I started my presentation, I was looking over what our flyer was and what the objectives are. And so some of you may wonder what's a surgeon doing here talking at the Heart Health conference, but I think it's all going to tie together nicely, and hopefully at the end we'll have all learned a little bit and talked a little bit about obesity, the epidemic of weight, and how it can impact every aspect of our health, not just our heart, but our entire health, and that there's a lot of really easy things that we can all be doing to help prevent bad things from happening for a lot of different medical problems. And also I want to focus on a little bit about what we offer here. So hopefully I'll go through the presentation probably in about half an hour maybe, and then there should be plenty of time at the end for questions. So hopefully I'm going to be able to make this work. It does seem a little bit delayed. So as I mentioned, we're going to start talking about what is obesity, what's going on with it in our world. So statistics from 2024, 1 billion people worldwide living with the diagnosis of obesity. And we're going to talk about what that is in just a minute or so. That's 880 million adults, 159 million children, and that really comes out to 1 in 8 people globally. So a real issue in our world today. It's dramatically increased over the last 3 decades. It's doubled since 1990. And in our teenagers and adolescents, it's quadrupled. So it's really becoming an even bigger problem. This is an interesting fact: increased prevalence in low and middle income countries. So just like we see in our United States, that people that don't have means to get healthy meals and good nutrition, obesity is a problem worldwide in those same kind of situations. So what does this cost? 4 million deaths, contributes to 4 million deaths annually in the world. 320,000 approximately in the US was what they estimated in data from 2015, okay? Obesity is associated with a significant reduction in life expectancy. And if you add smoking to that, if you have concomitant smoking, that even further reduces the issue of life expectancy. Central adiposity, that's when you have the apple core shape rather than the pear shape, that also increases the mortality. So where you carry the weight. Let's talk about what obesity is. So we use the BMI. The body mass index is the widely accepted standard or definition for weight status. And there's 5 categories. You can see the numbers less than 18.5 is underweight, Normal is 18.5 to 24.9. Overweight is 25 to 29.9. Truly defined as obesity, BMI of 30. And then severely obese is 40 or greater. Some people would tag that as morbidly obese, is another word that goes with a BMI of 40 or greater. This is now going to be a BMI chart. And this is easy to find. You can look it up, but if you look on the vertical axis, you see height, and on the horizontal, you see weight. And so you simply go down and look up what your height is, and then you come across and see what your weight is, and then you see where it meets. So for example, if you're 5'5", and you weigh 200 pounds, that's going to put you at a BMI of 33, if I read that right. But you can see how that works. And then it's color-coded for whether you're in the morbidly or severely obese category or just have obesity, and it shows these ranges. So it can tell you whether you're underweight, in the normal range, which is in green, normal, or whether you are in an area where you might be wanting to think about weight loss. Let's talk a little bit more about what higher BMIs are associated with. So, health morbidities. Obesity is now actually surpassed cigarette smoking as the #1 cause of preventable disease and disability. So that's how big of an issue this is. And this is just astounding. I'm not going to talk about all 230 of this, but there is a list of more than 230 medical comorbidities and complications of health that have been associated with being overweight or obese. But we are going to talk about some of them. And we'll start with some of the big ones that have to do with heart health. Okay, so let's talk about diabetes. Type 2 diabetes, strongly associated with obesity. It's insulin resistance, and it's characterized by hyperinsulinemia. Look at this number here. 80% or greater of type 2 diabetes can be attributed to obesity or being overweight. Weight loss of only 5 to 7% is associated with a decreased risk of becoming diabetic in a person who is pre-diabetic. So maybe your primary care doctor has said, oh, your hemoglobin A1C is kind of borderline. Or maybe they say to you, oh, your glucose is 2 numbers higher than it should be. That's kind of what you would call borderline diabetic. And so all you have to do is lose 5 to 7%. That's how little weight loss can impact the difference between being pre-diabetic and not having a risk of diabetes. If you are actually diabetic, weight loss of 15% can lead to complete remission of diabetes. A lot of people that have diabetes don't know this. They think once they've got diabetes, once a diabetic, I'm always a diabetic. Not true. If you're overweight and you're diabetic and you lose an average of 15% of the weight that needs to be lost, you can be no longer diabetic. So that's huge, because diabetes has all sorts of terrible medical complications in and of itself. Next, I think we've got abnormal lipids, another thing that contributes to heart disease. So obesity, so dyslipidemia is characterized by abnormal levels of fats, lipids in the blood, and it's associated with a change in lipid metabolism. You can get elevated cholesterol and elevated triglycerides. 60 to 70% of patients with obesity have abnormal lipids. So when you have the abnormal lipids, that of course contributes to heart disease. And now here's what we're here to talk about: cardiovascular disease. We've got coronary artery disease, high blood pressure, hypertension, peripheral artery disease. So in the vascular tree, like the lower extremities or the iliac vessels, cerebral vascular disease, strokes, even venous thromboembolism, atrial fibrillation, all of these have issues that are associated and can be at an increased, you can be at an increased risk for getting them from obesity. And we're going to talk about a lot of this here. So let's talk about how do you know if you're at risk for cardiovascular disease. And there are going to be 2 risk calculators that are about to come up. These are the current risk calculators used that doctors use today. The 2023 American Heart Association Prevent Calculator and the 2018 ASCVD Risk Estimator. And I'm going to show both of them, but these are things that will show what a person's 10-year and lifetime risk is for cardiovascular disease. And let's take a look first at the American Heart Association Prevent tool. And you can see, and this is an online calculator, so you could just type this in and you can start calculating your risk. But look at some of the things that are here. Obviously, they want to know, if you're male or female, how old you are. Look right here, total cholesterol. How about HDL cholesterol? Systolic blood pressure. Right here, the BMI. All these things that we were just talking about that are associated with obesity. Boom, 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 right down on the tool. These are the things that are starting to get factored in. Diabetes, glomerular filtration rate, so that's kidney function. But right here, all of these ones right here that are associated with obesity, diabetes, cigarette smoking. You have to go all the way down the list to get to smoking. Everybody thinks smoking is the worst thing for heart disease, and it is. It's terrible. But we can't minimize the impact of all of these things that are affected by obesity. Are you on a blood pressure medicine? Are you on a lipid lowering medication? Here we are with hemoglobin A1C, and the zip code, that's not part of it. But then you calculate, and it'll spit out your 10-year risk and your lifetime risk. So all these things that we were just talking about that are associated with obesity are what go right into this tool to calculate out your cardiovascular risk. The same thing can be said for the next tool, which is the ASCVD Risk Estimator. And I think, I don't know if this is 2 slides or if it's just one, but you can see it's got some of the same things. What sex, age, this one has race, systolic blood pressure, diastolic blood pressure, total cholesterol, HDL cholesterol, and I sort of think we might only have the first half of this slide because there are some more questions, and that doesn't look like we have the second half of it, and I'm sorry about that. But again, you can go through, you can just type this in, and it too will give you a 10-year and a lifetime risk, and it has the same type of factors, as you can see, as the other tool. So I'm going to deviate just a little bit from heart disease because I think it's so important to cover obesity and cancer. Who thinks that obesity is the contributor to cancer? It's like not what we all think about, but it literally contributes to all of these cancers that I listed right here. And because I'm a breast surgeon, I'm going to talk just a minute about breast cancer. I mean, nobody just stops and thinks, oh, I'm overweight, and so I'm at increased risk for breast cancer. Yes, because estrogen is stored in fat cells. And so most breast cancers are hormone positive. And so when we ladies become postmenopausal, and the estrogen is building up in our fat cells because we're overweight, which is what happens when we become postmenopausal because the metabolism slows down, all of a sudden that big time increases the risk of getting breast cancer. And then if you do get breast cancer and you're treated for breast cancer and you're overweight and it's a hormone positive breast cancer, you're at increased risk for recurrence, and the medicines aren't as effective. So obesity is a huge risk factor both for getting breast cancer and for not doing as well with breast cancer. And you can go down the list of all these other cancers that I listed here, and some of them are big ones here: pancreatic, ovarian, stomach. I mean, these are bad cancers, and they all have some kind of an association or increased risk with obesity. And I really just picked the big ones. And look at this: 40% of all cancers diagnosed in the United States may have some association with being overweight or obese. So not just heart health, but our entire health. The two big things that affect Americans, heart disease and cancer, obesity is a big risk factor for. And then just one last thing about comorbidities. Osteoarthritis. Obesity is horrible on the back and the joints. Gout, gallstone disease, infertility. There's ladies that try to have a baby and they can't. They lose 50, 70 pounds. All of a sudden it happens for them. So a huge contributor to this: polycystic ovarian syndrome, depression. It's a terrible battle for people when they're trying so hard to lose weight and they struggle. It's so depressing for them. Dementia. So being overweight can increase that risk. And sleep apnea, which of course also is a big time risk factor for heart disease. And that's really in the news right now, sleep apnea, and how detrimental that is to our health. So it's all connected. That's really the message that I wanted to get across about the comorbidities. So with that, I'm going to segue into what can we do about it. This is myself a few years ago, and our nurse practitioner, Tracy Rocky, she's fantastic, and she and I are currently leading our multidisciplinary UnityPoint bariatric weight loss program right now. I'm the medical surgical director, and Tracy kind of heads the medical arm of the weight loss program. And we are surrounded by a great team of assistants. We have nutritionists, we have physical therapists on our team, we have mental health specialists, we have trained bariatric nurses, because I see familiar faces. Some of you gals know, and guys and gals know Stephanie, my nurse. She's been with me for over 20 years. She is so unbelievably knowledgeable about weight loss surgery. And I'm excited to tell you that we have recruited another surgeon who's going to be joining me in our practice. He's another University of Iowa grad. Super excited about this young man, Dr. Siegel. He's coming in just a couple weeks, and he has additional training in bariatric surgery. So we have a lot of exciting things going on in our bariatric program, and Dana, who introduced me, is our bariatric director of our program. She kind of heads the whole thing, and we are 2 weeks away from going for our Center of Excellence designation, which I'm very excited about. We're going to be getting accredited by the American College in just 2 weeks. And that's been a lot of hard work in the process, but that's 2 weeks from now. So wish us luck. I I asked Tracy to put together a little bit of a slide of what she likes to do when she does medical counseling for weight loss and nutrition counseling. Now, Tracy is a nurse practitioner in her own right in internal medicine, and this is just her area of specialty. But she's in our clinic a couple days a week, and she counsels people on nutrition and exercise and focuses on these chronic illnesses that I talked about. She talks about incorporating lifestyle changes, nutrition, healthy lifestyle practices, exercise, and she does counseling with this. And here we are with what she does that I don't do, because I don't prescribe these meds, but she does it. All the GLP-1s. So the Wegovy, the Ozempic, the Zepbound. Zepbound's really been really effective. I think of all the meds, I think I might like the results from Zepbound the best. And I'm going to talk a little bit more about how these meds can be incorporated into weight loss journeys as we go along. But Tracy prescribes those. And of course, you may recognize some of these meds as medications that are used for treating diabetes. Some of them are approved for just diabetes. Some of them are approved for the use with weight loss as well. Insurance plans differ as to whether or not they're only covered for the treatment of diabetes, or whether they're whether they'll cover it for weight loss as well, and that varies from insurance to insurance. And when insurance doesn't cover it, currently right now they're in a high demand and they're very expensive. But they can be effective both alone and in coordination with surgery as well. So Tracy does initial appointments and she does follow-up appointments. She follows patients after I've operated on them in the bariatric clinic and assists with continued medical and nutritional counseling. Let me just cover a little bit of some of the things that before I switch to the next slide, let me just cover a couple of the things that she encourages. She can work with patients on any kinds of diets, like calorie monitoring. We have physical therapists that assist in the exercise component. She encourages food journaling. We encourage high protein diets. We have recommendations for vitamins. So we have a comprehensive, I like to call it the medical arm of our weight loss program. So either people who are just not interested in surgery, or maybe they don't quite qualify for surgery. And I'll talk about that in a minute when I transition to the surgery area of our conversation. But she does all of the non-surgical management. And then here we go with my favorite slide, the surgery slides. So I offer 2 surgeries, and they're the gastric sleeve and the Roux-en-Y gastric bypass. And I started, I'm really proud to say this, but I've been doing bariatric surgery for over 30 years now, and I trained under Dr. Edward Mason. He was a professor emeritus at the University of Iowa when I was a third-year medical student, and he invented bariatric surgery. So he's the pioneer of bariatric or weight loss surgery, Ed Mason. And in the American Society of Metabolic and Bariatric Surgeons, they have all sorts of awards with his name on it. So I feel a little bit like I've been doing this from the beginning, and I love my roots in the surgery, but I do have a long history with bariatric surgery. And so I started out with the gastric bypass because that was really the main operation that was done back in the late 1990s. And when I came here to the Quad Cities, I joined Dr. Phil Siegert's practice. I know some of you in the crowd are gonna know him. And Dr. Siegert was just the most amazing surgeon, a wonderful man. And so I learned to do the gastric bypass even better under him. And so he was a Trinity bariatric surgeon for a really long time as well. He's retired and since passed away, but a wonderful surgeon at Trinity. So Trinity's got a long history with weight loss surgery. In the early to mid 2000s, we dabbled in lap bands, a restrictive operation, and they're not even they're almost not performed anywhere anymore because they had all sorts of problems, complications, the lap bands. But the idea was a restrictive only operation. And I am going to come around to a point here because it's key to the difference between a sleeve and a gastric bypass. A sleeve, when you look at this picture, you can see that everything is still connected properly. Okay, here's your mouth up here. The food goes in the esophagus. It goes into this sleeve or your stomach, and then it goes on down the normal route through your intestines. And so the sleeve is primarily functioning based on restriction. It restricts how much food that you can take in this itty bitty little tube of a stomach. And we basically just removed all of this. We remove it, and that's why it's called a sleeve. So restrictive only. Contrast that to the gastric bypass, which is a small pouch, and you can see a rerouting of the intestines. You're bringing up, and the picture just doesn't show all these small intestines that are still down here, but you're bringing up this loop of bowel, and you're basically bypassing this whole segment so that it doesn't absorb as much. So not only are you restricted in how much you can eat, but you don't absorb as much of what you do eat, okay? And just to make sure this is correct, I read this, and the en part is French, but the person who invented this operation is César Roux, and he was from Switzerland. So the Roux-en-Y gastric bypass was actually initially an operation done and designed in the late 1800s for resection of gastric cancer. So for a stomach cancer that was in the stomach. But anyway, César Roux, Roux-en-Y gastric bypass. And so when I started doing gastric bypasses, we did all of these in an open fashion with a big incision. And now today, I do all of my bariatric surgeries with the robot. And I am so proud that UnityPoint has a robot at every single campus. And I think we're about to get, I hope, one or maybe even two of the brand new state-of-the-art Da Vinci 5 robots. Those just came out on the market. Available a few months ago, but the robotic surgery has literally revolutionized how fast a person recovers from bariatric surgery. And whereas back when I started doing these operations here, we kept people in the hospital 3 and 4 days from a gastric bypass, I am almost doing sleeves outpatient, and they're only overnight. And the gastric bypass is just overnight. And the recovery, I have people tell me that they are back to work after a sleeve in less than a week. Now, not doing vigorous activity, but to a desk job. So really, really amazing recoveries. So I've spent a lot of time on these operations, and I'm sure folks may have some questions about it, but I want to get on back to what we're here to talk about, which is one last thing about cardiovascular, and then I'm going to open up to questions. But there is a great study that was just published in 2022, so really, really current data from the American Society for Bariatric Surgery. I'm a member of that. And this is the study, and it used, guess what, that risk calculator. They used that risk calculator that I was just talking about earlier in the presentation, and we've got thousands of patients, 2,771 gastric bypass patients, 6,256 sleeve gastrectomy patients. We've got a lot of women. We've got Caucasian, Hispanic, and African Americans, so it's a very good cross-section of population. We've got, people that are 36 to 56 years old. Here we're talking BMIs plus minus 43, so 35 to 50 BMIs. And they did this predicted 10-year risk of cardiovascular disease. So before surgery, if a person's, the average risk was for a sleeve, if it was 4.1% and 5.1% for roux, and recognize that we often do roux on people that need to lose more weight. And so the risk is going to be higher for people that are more obese. Look at the statistics. After surgery, at 1 year post-op, you take people whose 10-year risk of having cardiovascular disease is of significance, is 4.1%, and you take it down to 2.6%. And when we talk about these risk of disease, it's a major event, not just developing a plaque. So big time decrease for both the sleeve and the roux. And when you look at long-term risk, the folks are maintaining these significant decreases in their risk. So bariatric surgery, both the sleeve and the roux, are equivalent in decreasing the risk of developing cardiovascular disease, which really kind of makes sense, because the bottom line is it really doesn't matter how you lose the weight. It matters that you lose the weight in a healthy way, and that's how you decrease the cardiovascular risk. So I think we're to my questions slide. Yes, we are. And I'm just going to check my pager, and it's fine. So, and I was right. I spent about 35 minutes. So I'd love to take questions. Yes, ma'am.
I have one. How come thyroid disease is not in there as an issue of heart disease? Because a lot of times the heart issues and the fat issues are from that. And I have that issue, and right now I'm battling with my doctor what my normal range is supposed to be.
Sure.
Because I don't feel good. Even though
should be.
It's an average number.
Yeah,
but
you're right. It should be. That's an omission on my part, because you're right. Hypothyroidism can absolutely contribute to weight gain and obesity. You're absolutely right. And in fact, that's one of the things that has to be normalized before we can submit for an approval for bariatric surgery. Yeah. So absolutely. Excellent question. Yeah. Yes, ma'am.
Is there ever a reason why you'd have to go back in and adjust a Roux-en-Y or a sleeve?
Yeah, a revision surgery. Yeah, absolutely. So a great question. And part of the reason that I love a good restrictive operation when you can do it. I didn't really get into this, but I'm glad that you brought it up. The benefit to the Roux-en-Y is faster weight loss and probably more weight loss. But the list of potential complications that can occur from a gastric bypass and the nutritional deficiencies that can occur from a gastric bypass last for a lifetime, and that list is very long. And a person who has a gastric bypass, and it's not always, I'm not even for a moment saying that it's their issue, but forever you're married to that operation, and you have to eat properly and you have to do things right, because you can get terrible bacterial overgrowth and chronic abdominal pain, and all sorts of problems that can occur 5 and 10 and 20 years down from a gastric bypass. And some of those things can end up requiring revisional surgery, or a person can get a bowel obstruction at what's known as Peterson's defect, and you can end up having to do an exploration for a critical malrotation bowel obstruction. So yes, as far as the sleeve goes, most of the time when a person has a problem with the sleeve, like they have, one of the big problems that can occur from a sleeve is paradoxical heartburn. So because it's kind of a high pressure system, a person who's losing all this weight can be like, I'm losing all this weight. Why am I getting worse heartburn? And it can be that the sleeve is just not, it's a little bit too tight for them, and it's overwhelming their lower esophageal sphincter. Most of the time you can't revise the sleeve. You end up having to convert the sleeve to a gastric bypass. So you're totally right. Revisional surgery exists for both sleeve and gastric bypass. Sometimes you're going to revise one of those operations because the person out-eats the operation and they still need to lose weight, and they want to try again. And you can convert a sleeve to a gastric bypass. You can't convert a gastric bypass back to a sleeve. But yes, there is a lot of work that has to be done, and it's very complex surgery. I'm doing a lot of that I said I was never going to do, but I'm doing it now because I can do it on the robot. The robot has revolutionized what we can do in a minimally invasive way for folks, and it's just really neat stuff. So yeah, great question. Yeah. Other questions? Yeah, yes, ma'am.
I was wondering on medications that can be used, they work primarily like on the brain, is some part of the brain, is that correct?
Yeah, so
And
yes.
once you start taking them, can you get off of them, or?
So I did, because I thought I was going to get that question. I did look into the mechanism of action of all of those different meds, and I will tell you that each one of them has a slightly different mechanism. They're GLP-1 agonists, and they work on the glucagon peptide receptor, and they do work on the mind to decrease appetite, and they also delay motility and transit through the GI tract. And as I mentioned, some of them have different mechanisms, which, like I said, I told you I've been seeing some of the best results from Zepbound and such in patients that are taking these meds. But you can go off of them. Anecdotally, I've heard and I've seen that some people, if they don't have behavior modification, will then start to gain weight again when they go off of them. Okay, so I have seen some of that. And interestingly, because one of their mechanisms of action is delayed motility and stuff sitting in the stomach, for example, if you're planning to have an operation of any kind, anesthesia will make you go off of the medicine a full week before, you have to be off it a full week before you have any kind of general or monitored anesthesia. Yeah. Yes.
So have these things been out long enough they've got any long-term effects of what it does to the brain?
No. And a very interesting question. I have not seen any data on that. A very, very interesting question. I mean, and when we talk long-term, you know, there's 5 years and then there's longer, and I would answer no. I don't know of, I certainly don't know of anything detrimental, and I'll tell you that as I said, I don't prescribe them, but I recommend them, and the bariatric surgeon society liberally uses those drugs to assist. For example, a sleeve patient doesn't have quite as much weight loss as he or she desires. You add one of those medicines in, boom, there it is. They're 100 pounds that they wanted to get off. So they can be highly effective. And we certainly don't know of any long-term, but, time is what, you need much more time to see what the long-term ramifications are. Other question? Yes, ma'am. Yeah.
You mentioned behavior modification.
Yeah.
I imagine I'm not the only one who's done every single diet in the world that's out there. Weight Watchers, Atkins, cabbage, whatever.
Yeah.
And they all work while you work the diet, but eventually you step beyond that and you go back to your own normal and the weight comes back on.
Sure.
So
let me speak to that. So let me speak to that for just a minute. Yeah.
Bariatric, because
So-
you have to be even more strict.
Yeah. So it's the biggest and best point that gets presented tonight. And so thank you for bringing that to the forefront. You can out-eat a bariatric operation too, okay? It is life change. And that's why not just our program, but bariatric programs in general are really trying to get to the crux of the life change. If you don't internalize the behavior modifications, the person will out-eat the sleeve, or at least gain some of the weight back. You can out-eat a gastric bypass, which is hard to do, but 30% of people will gain substantial weight back. And I tell this too, I'm very straightforward with, all of my patients. There's a reason that the weight comes on, and some of it is metabolism and some of it is behavior. And so, it's nobody's fault. It's a combination of all the factors. But whatever the problem was, that problem has to be addressed. Because, for example, if you do a sleeve on someone and their problem was that they love Starbucks lattes, no sleeve is going to stop a Starbucks latte from going down. It's not going to, okay? So liquid calories are a real problem. If your problem is grazing or nibbling, a gastric bypass is not going to stop that, because even if your pouch is this big, if a person doesn't mentally correct the desire to eat the pretzel every 15 minutes, it's not going to change it. So there's no medication, there's no operation, there's no diet that is the end all be all cure all to all of it. But it is the whole program that we try to put together of the support that the person needs, the analysis of what the behavior is. But in the end, every single thing that every doctor has to offer, every healthcare provider has to offer, is a tool in that person's hand to use to try to improve their health. And like I said, I've been doing this a long time, and I just simply tell my patients, you have to want your health and your life and you have to want that more than whatever it is that the other thing is. And that's true for everything, whether it's cigarettes or whatever the issue is, whatever the health issue is that somebody's battling and trying to change, you have to want that health, because you have to fight for it every day for changing the behaviors, because the person who really does the weight loss is that person. I do one operation. They're the ones that succeed with the life change. So, and I think it's so rewarding to see. Yes, ma'am.
Is there times that when you've done a Roux-en-Y or sleeve on someone and they've lost so much weight, but they can't complete their weight loss like they want to?
Yeah. That's exactly what I was alluding to a few minutes ago. And the population is often, it's so unfair. Middle-aged women in their 50s, they'll have a sleeve. They need to lose 150 pounds. They lose 75, and they just plateau, okay? That's where those GLP meds I'm starting to liberally say, okay, hey, you've done phenomenal. You're still following the rules. You're exercising 4 times a week. Your sleeve looks normal size. You haven't stretched your sleeve. How about we add in this medicine? And that can be very effective. But yes, yeah, yeah. Other questions? Yes, ma'am.
Is there an age where you stop doing the bariatric surgery?
So not a set age. I would say 70 is kind of soft, but a little bit it has to do with health and medical comorbidities too. You know, if I have a 60-year-old and, you know, they're on 4 liters of oxygen and the cardiologist says, you know, moderate to significant cardiac risk, I'm going to say, not here, you need tertiary care. So it's really an individualized decision. Good question. Other questions? Yes.
Can someone connect with your office or group to discuss other options?
Yeah.
Someone's had like a gastric bypass or the sleeve, but they can't get the rest of it off.
Of course. In fact, I'm sure we have our information either at the desk or I'm pretty easy to find. And I'm the call doctor for the next 7 days. So anyway, yeah, just a little joke. Yeah.
There's a postcard that has all of our information. Additionally, there's an application for our bariatric program that you can submit as well, but it has our address and phone number on there.
Other questions?
You,
Yes, ma'am.
like if somebody's on heart medicine or diabetic medication, cholesterol medicine, after you do a procedure, do they come off of any of that?
Yes, absolutely. That's one of the hugest benefits. I mentioned that statistic about the 10 to 15% and the diabetes can resolve. That's like the first med to go is the insulin, absolutely. And hypertensive meds, lipid medication, and the impact on the joints. People avoid knee surgeries, they avoid hip surgeries, they are able to get off of those chronic pain meds 100%. It's these operations, the weight loss is life-changing for folks. Yeah. Who else had that? Yes, ma'am. Yeah.
What is to go back to the medications, do you find for insurance that you have to have X amount of weight to lose for the insurance to cover it, or how do they figure that?
You know, I honestly, I think Tracy could perhaps answer that question better because she's the one that actually deals with that. If you're diabetic or pre-diabetic, almost all of them just cover it. But I'll bet you have to hit a BMI of like 35 to qualify. I'm not sure of that though, so don't quote me for sure on that. Okay. Other questions? Yes.
What if you want to just lose 15 pounds or 20 pounds or something? I don't want bariatric or something.
Well, I think that speaks to any option that you would have in the medical arm. The diet and diet modification, Weight Watchers, things like that can be very effective for 10 to 15 pounds. You wouldn't qualify for bariatric surgery if all you need to lose is 10 to 15 pounds. Some of those medications might be an option for you. I see the oxygen. I don't know whether there's any, that would be something that, like I said, I'm a surgeon and I don't kind of evaluate people individually. You'd probably want to talk to your primary doctor about that. Yeah. ZEP, Z-E-P, Zepbound.
On the news today, you can go to the manufacturer and get the coupon for $25.
Yeah. That's awesome. Thank you for sharing that. Other questions? Yes.
I'd just like to make a comment.
Oh.
I'm a living example. I had the Roux-en-Y back with Dr. Seeger back in the 90s. And I'm a grazer, and I easily gained back 100 pounds, very easily. Because if you nibble all the time, like the doctor says, if you have that Starbucks latte or that molded milk from McDonald's or whatever, you could easily gain it back. And I've been like this. I've been on every single diet in the book, and I've lost 100 pounds several times. If you do not modify your behavior and your lifestyle, you'll easily gain it back. So
thank you for sharing that. Yes, thank you.
So,
And thank you for mentioning Dr. Siegert, a great man. Yeah.
he was a good doctor.
Yeah.
And the surgery was successful. But
He did mine also, but a question, my sister has had the room a long time ago. Why is it that a lot of like ice cream or milks or things like that tend to make you sick?
Yeah.
you can't ever eat ice cream again.
Well, it's the sugar, so like it's so fascinating. Let me see if I can make this go back. But we call this right here the gastrojejunostomy, or the GJ, gastrojejunostomy anastomosis. And you'll notice that, look what's missing: the duodenum, the pancreas, and of course the liver should be, and the bile duct should be right here. Well, what comes from all of this area? Digestive enzymes. That's what comes from there. So right here, all of a sudden, you've got food, sugar, simple sugar, alcohol, going right into this pouch, and boom, it hits the jejunum, okay? And that's what causes that problem, is the simple sugar or the dairy is going straight from the stomach. It's not mixing the way it should. It's not mixing with the digestive enzymes that it should, and it's hitting absorption. The jejunum, our small intestine, is where nutrients are absorbed. And so that's where you get, everybody talks about the dumping syndrome. And so you get, and right away you think it necessarily means that you're having a dumping event, but that's actually not necessarily the worst part of it. The worst part of it might be the sweats and the massive sugar and the feeling like you're going to faint and the heart palpitations that happen from sugar getting absorbed straight out from the, and then the event happens where you have the diarrhea. But that's from that massive rapid absorption across the gastrojejunostomy. It's also the reason that a person can hardly ever drink alcohol again. So if you're someone that enjoys one glass of wine, you might only be able to enjoy 1.5 sips of wine because it's immediately absorbed with immediate alcohol impact. There's no mixing in the stomach. There's no processing in the duodenum. And so actually there's a lot of people that end up struggling with alcohol issues after having gastric bypass too, because of that. So these are just some of the many undesirable issues that exist with gastric bypass that don't exist with a restrictive gastric sleeve. Other questions? Yeah.
That one study that showed, well, it was a 50% reduction in your risk, but your risk only started out at like 4.1%.
And remember, those are averages. Those are averages, and those, and I didn't spell out. That's just the abstract of the paper. That doesn't, in that journal article, that'll kind of go through all the different percentages, but it's substantial. And the main key takeaway point of that is really to show the significant and the equality. That paper set out to determine their objective was to determine, is the sleeve as good as the gastric bypass for achieving that weight loss? And remember, all of those people have to be people that are well enough to have these surgeries. So by definition, they are people that have this weight, but they haven't gotten to a point that they're not healthy enough to have the operation, okay?
I was thinking the general risk of cardiac issues for an obese person is a lot higher than that.
And it probably is. But remember, the age range was 36 to 56. So these were younger individuals too, okay? You know how to analyze an article, don't you? Yeah, pretty sharp. Other questions? Yeah.
So in the sleeve gastrectomy, the pancreas, is it allowed to add its key digestive elements and what?
100%.
Pancreas, or does the pancreas?
Amylase, lipase.
Your pancreas, your gallbladder?
What? I'm sorry. What's the question?
I guess the bottom line is, are those all of the organs that are entering into the digestion?
Nothing gets rerouted in a sleeve. It's all the way God made it.
Okay.
Yep.
Okay.
Mm-hmm.
Thank you.
Yep. Other questions? Well, I've really enjoyed talking to all of you, and I hope that you've all taken something away from it. And if you have any other questions, please don't hesitate to reach out.
Real quick before you leave.